afternoon, everybody. Thank you for making the time to come out. Certainly there's coffee and donuts. If you haven't grabbed some, go get that now. If not, you can get some afterwards. It's a real pleasure to have you all back in a virtual to in-person transition right now as we go through this is our first in-person seminar in a while. We enjoyed having the online seminars. It allowed us to connect with people that would not physically be able to come. But we're super excited that we can get back together as a group and listen to some of our excellent people in the faculty. So, without further ado, let me introduce you to our speaker today. Joyce Slater is a professor of community nutrition in the Department of Food and Human Nutritional Sciences here at the University of Manitoba. She teaches food and nutrition literacy education and public health nutrition. Joyce uses mixed methods and participatory approaches to conduct research on food and nutrition security, the role of food literacy in well-being, and nutrition epidemiology. Her research has been funded by the Heart and Stroke Foundation, the Social Sciences and Humanities Research Council, the Canadian Institute of Health Research, and the Canadian Home Economics Foundation. Joyce is a registered dietitian who worked in various public health organizations for 18 years before obtaining her PhD and joining the University of Manitoba. So please help me welcome Joyce.
Yay! Thanks, Nathan. Hi everyone, thanks for coming out on a Friday afternoon. And Jim told me there's a Bomber game, so I'll make sure you're out of here early. And thanks for having me be your first in-person seminar in over 2 years. So that's kind of exciting. I'm still kind of getting used to being in the classroom and all of that. So without further ado, today I'm going to talk to you about one of my studies called the FANS study, which is an acronym for Exploring Food and Nutrition Security in Manitoba Youth. Do our traditional land acknowledgement. I'm not going to read it because you can read it, and give you another 10 seconds for that. So, background on the study. Why would we do a study on the food and nutrition sort of status of youth in this province? Well, back in 2009 was the last youth health survey that was done by a coalition led by actually Cancer Care Manitoba, but the province was involved in it. When I say the province, I mean the provincial government, the Department of Health, and some other stakeholders. And there was supposed to be another iteration of the youth health survey done in, I think it was around 2015. And I was part of that group, and we were going to add a nutrition module onto it, and then it got scuppered by various government bodies, and that youth health survey was never done again. So we also wanted to look at survey research versus population-based data. Okay, so survey research being, you're investigating a specific phenomena through surveys, and that's what this is. It's a survey that we did versus population-based data, which is, what can we track over time in the population, and the government does that, through your health numbers. But it's very difficult to do broad-scale population-based research as primary data collection as a researcher. You usually are using other data sources to do that. So this study actually is using a little bit of both. And then the added value of data linkage. So it's one thing to go do a survey and say, okay, this is what we found. It's another thing to be able to link the information you find with what I just mentioned, the other information we have about all of us in the province through our unique health number. So the government has a repository of information about all of us that it's got not just health information, it's got social services information, education information, all kinds of hospitalization data about all of us. Now, as researchers, we can't just go and say, hey, you know, I'd like access to this. It's a very big and involved process to access the information in, you know, the government's database. There's lots of protocols around it, and we have a center at the University of Manitoba called the Manitoba Centre for Health Policy that actually helps us do that. So that data linkage allows you to amplify what information you collect through your survey by connecting that information for each participant to their, what we call administrative data. Okay, that's kind of boring, so let's get to some more interesting stuff. So back in 2016, because we weren't doing that youth health survey I just mentioned, I did something called the Youth Nutrition Pilot Study, and this was actually funded by, Jim, what was the name of that organization that Leanne used to head up? MARN, Manitoba Agri-Health Research Network funded this. And what we found was, this is really busy and should not be on a slide, it's a handout that I have of this, but we went into one school division, Seven Oaks, and did, I think it was like around 120 or 130 students. We did this pilot study to test out, the tools that we wanted to use and kind of see what we'd find. And, the only things I'm going to point out here in my little thing isn't working, are that, we found out that these are the 4 food groups, that this is the proportion of students that were not meeting their food groups on the day before, and that translated into, up here you can see they were short on all of their essential nutrients, fiber, male and female, vitamin D, calcium. I mean, there's more nutrients than that, obviously. But you can see sodium, the green bar, is way higher than what they need. So that was a real clue that things aren't that great for this small group of grade 9 students. And you're going to say, well, why did you pick grade 9 students? Because they're of an age where they can use the data collection tool. That was the age of the youth health survey. That was the group that was being done. So it just sort of made sense to continue with that. So why is this important? Because there was a big study done by the Lancet Global Burden of Disease group in 2019. And I think this is a really important quote out of the study, conclusion, that suboptimal diet is responsible for more deaths than any other risks globally, more than smoking and tobacco. So highlighting the urgent need for improving human diet across nations. And I always think, why does this not get attention? Because it's such an everyday activity. It's not like, ooh, that person eats, like that person smokes. We all eat. So it sort of gets pushed into the background of our everyday lives. But it came to the forefront a bit during COVID, and I've just popped in a couple of media articles here. There were lots of stories about people binge eating. Yeah, they were making homemade bread and whatnot, but then they were also binge eating, skip the dishes in front of the television. And we also know that childhood obesity actually increased during COVID for a variety of reasons. So the issue of nutrition is not just sort of a, mild concern. Here in Winnipeg, this is another project I have called the Winnipeg Food Atlas. But on that Winnipeg Food Atlas is some data about diabetes. The majority, about 95% of cases of diabetes are type 2 diabetes. And this just goes to show that, diabetes, this is I popped out the 35 to 49 year age group, which is relatively young. In past decades, we would think of type 2 diabetes as being a disease of the elderly. And the reason I've chosen diabetes here is because it is lockstep linked, especially type 2, to our diet and, subsequent weight gain from our diet. So we can see that it's increasing in this age group. From 2016, the projections go to 2030. You can see it's almost doubling in this age group. over that time period. And then I've just highlighted what the cost projections are for that over that time period. This is just for the Winnipeg Health region. Okay, it's not for the whole province, it's not for Canada. This disease alone is projected to cost over $120 million by 2030, just for this age group, okay, not for people over the age of 50. So what we eat is causing us to be sick, and it's expensive. So the aims of our study were to investigate food insecurity and nutrition insecurity, I'm going to define those for you in a minute, in Manitoba youth and their relationship to each other, and to social education and health outcomes. That second bullet, those are things that we're going to bring in through our data linkage, okay? And of course our goal is we want to affect programs and policies so that children and other people will be able to eat healthier diets. It's a big study. We have a lot of academic co-investigators as well as community partners, both in the school system and outside of the school system. So because these are grade 9 students, we had to go through schools to access participants. I would never do it again, but we have 37 school divisions in the province of Manitoba. It's sort of like working with 37 different countries. And it was a very intensive primary data collection project. Oops. So let's define these. Food security is when you have sufficient resources, primarily in our society, that means money, to obtain adequate food. And the flip side of that is if you're food insecure, you don't have enough resources, okay? And nutrition security is having adequate nutrition status in terms of micro and macronutrients, okay? So the flip side being you don't have adequate nutrition status. So why is it important to define these two things? Because food insecurity in itself, or food security, people who have food security, that is insufficient to make you nutrition secure, okay? Nutrition insecurity is people aren't eating a healthy diet, okay? And what I wanted to study is, and there's evidence to support this, that there's many people in society who are food secure who aren't nutrition secure. So they might have adequate resources, but they're not consuming a healthy diet for a variety of reasons. Now, at the same time, if you are food insecure, you're probably nutrition insecure, and it's probably these two sort of work together to make even more disadvantage. Okay. So Manitoba has too much food insecurity. We're a poor province. We have a very high rate of child poverty. We've got a lot of northern communities that have incredibly high cost of food, along with higher rates of poverty in those communities. We've got that picture was taken, I did some work with the Bear Clan pre-COVID, where they had started a program where they were giving away surplus food from a number of grocers, and that's a lineup on Selkirk Avenue around the corner for people going for free food there. I think in future I'm going to turn that into black and white, because I think that looks like something from the Depression. But it's from 2019. But we also have too much nutrition insecurity. We are home to Skip the Dishes, huge economic employment success story for Winnipeg, but of course, what you're ordering through Skip the Dishes is not necessarily, it's very difficult to eat healthy food from restaurants. And Skip the Dishes isn't an occasional thing, it's becoming more and more of a mainstay for many people, especially young people. Okay, so we wanted to study this in this cohort of grade 9s. So how do we come up with them? I'm not going to go through this. The gist of it is we approached all school divisions that had, I don't have the exact number here, but had a certain number of grade 9 students. There's many school divisions in the province that have very small divisions. there's small school divisions that by the time you drill down to how many, they've got schools in small communities, and it was just cost prohibitive, because to go and do that data collection, my research coordinator had to fly or drive and spend the night, and so we stuck with larger school divisions, but we did go to northern divisions, rural and urban divisions. Tried our darndest to get Brandon on board, and they just wouldn't. So urban is Winnipeg. So we ended up with 14 divisions and 62 eligible schools, and 37 eventually participated, which was a total of 4,300 grade 9 students. And we had to send paper consent forms home with all those students. Couldn't do it electronically because if you were listening to the first part of my talk, we asked students' parents to give us their health numbers. So we could not collect those electronically. So we were reliant on paper consent forms. And we had 1,587 students' parents consent for their children to participate. And what isn't on here is that almost 1,000 of those parents gave their students health numbers. Okay, so how did we collect information? We collected information on diet, on food security, and food behaviors and health indicators. So the diet was collected from a 24-hour diet recall called the WebQ. It was developed at the University of Waterloo by Dr. Rona Hanning, and it's a web-based, the students, they all came into their school library where the computers were. They sat down and they themselves went and did this interface where they said what they ate the day before. And we had research staff go and supervise this to see if they had any issues, and they worked through that. They also filled out the survey questionnaire online as well, which asked questions around. There was a module for food security that they answered, and then there were questions around health behaviors related to food, things like, how often do you eat breakfast, how often do you eat lunch, where do you eat breakfast and lunch, do you eat with your family? There was a whole host of questions like that. And then what we call self-reported health indicators. They provided their height and weight, they rated their self-rated health, they said, were they trying to lose weight, were they trying to gain weight? A whole series of questions like this. So we ended up, it was close to a 50-50 male-female split. There were more females. And then, there was the option to not report on gender. So we had a few people not reporting. The vast majority because it's grade 9, were 14 and 15 years old. And as I mentioned, we did have rural, urban, and northern. We were able to segment the students into those 3 areas. We also asked if students had lived in Canada less than 7 years. So those students who responded to that, they were asked if they were born in Canada, and if they were not born in Canada, what year they moved here, and we were able to calculate if they had lived here less than 7 years. That was a number decided on by our newcomer partner organizations, and we did a sensitivity analysis to sort of see what that cutoff should be, and it was 7 years. We also asked participants to self-identify as Indigenous, First Nations, Métis, or Inuit. Okay, so what did we find? We got a lot of data from this, and we're still analyzing it. Today I'm going to present some descriptive information on dietary intake and quality, food security, body mass index for all participants. This isn't segmented by the Indigenous or the newcomer groups. So I have a little graphic here because I call this the laundry list of nutrients that we analyzed. So it's a laundry list. I'm just going to point out here that, this shows us that, current dietary guidelines for vitamin D, you can see them there, and that at the 25th median and 75th percentile, neither males nor females were meeting this. And no, we don't just get vitamin D from our food. We do get it from sunlight, but in our climate, especially you know, as the further we get north, it becomes more and more difficult to synthesize vitamin D. We also can get it from supplements, but we know that supplement usage is quite low. We didn't ask about supplement usage, so that's a limitation of the study. Okay, so this is a little more visually friendly, this graph, maybe not much more, but we've popped out a series of, you know, key nutrients. I don't think fiber is a micronutrient, maybe I should relabel this. But we've got vitamin D, iron, folate, calcium, and zinc. And you can see that, especially for the first two, almost no students were meeting their recommendations for these nutrients on the day before. Iron, a little bit better, but you can see that it's, when we get to folate, folate's a very important, Dr. House can tell you all about folate, nutrient, especially for young women. So you can see that significantly more young women were not getting enough folate on the day before, nor were they getting enough calcium, and nor were they getting enough zinc. So what does this look like when we look at food that they ate? Well, it looks sort of like this. So you see on the left, there's a list of food groups. And for those of you who are up on the new food guide, the new food guide doesn't have food groups. So this is food groups from the old food guide, which in the vacuum of servings in the new food guide, we had to use the old food guide to evaluate their intake. There is a new method that's just been published. I'm actually one of the authors on it, for assessing food intake from, or dietary quality from the new food guide, but that's another story. So this is the old food guide, and what we can see here is, this is the total, both males and females. The percentage who were not meeting their servings the day before are pretty significant, and you can see it's 93% there for males and females, or 93% for fruits and vegetables. But it's still pretty high for most of the other food groups, and so you're going like, well, why is that? What are they eating, right? Well, we've got this category called other foods, and we can see that on average there were 4 servings of other foods. That's, you know, everything from soft drinks to salty and sweet snacks and anything that doesn't fit in those 4 food groups. And this was very interesting. We segmented what we call energy intake groups. So we made 3 groups, those with less than the 25th percentile of calorie intake, 25 to 75th, and then more than the 75th. So we took everybody and their energy intake and calories, lined them all up, and then sliced it at the 25th and 75th percentile. And then looked at the mean percentage of total servings of those food groups. So the little legend is right here of what those colored bars are. But what was interesting is that the more food people ate, you know, we typically in nutrition, we like to say, well, you know, people eat more food, they eat proportionately more of the same food that people that eat less food do. And this isn't the case with this group. What we're seeing is those that had more calorie intake, and yes, there are probably more young men in this group, we're having a lower proportion of fruits and vegetables and a higher proportion of those other foods. So just because they have greater caloric needs, or just because they're eating more, doesn't mean that they're proportionately eating the same amount of food groups as lower calorie eaters. So yeah, they're actually having a worse diet the more calories they are eating. So that's what this is just pointing out here. Fewer fruits and vegetables and more other foods. So we thought that was kind of interesting. So diet quality, the way we measure that, how am I doing? Is something called the Healthy Eating Index. And it's a measure of diet quality independent of quantity that can be used to assess compliance with dietary guidelines. And again, this is to the 2007 Canada's Food Guide. And it's a way of taking the types of foods people eat in those food groups, and you stick them in a computer program, and it comes out and it says, based on the number of servings of these foods that you're having, we're going to give you a number for your diet quality from 0 to 100. And we've also come up with a cutoff saying you've got a poor, an okay, or a good diet. So, okay, they're really called poor, needs improvement, and good. So what we found here was that, again, for the total group, hardly anybody had a good diet. Most of them needed improvement, and over 25% had a poor diet based on the record that I gave for the day before. Independent of how many fruits and vegetables and whatever they were having, the Healthy Eating Index actually kind of confirmed that, things aren't so good. And, males were even worse than females for having a good diet. Okay, so that was the nutrition piece of it, the nutrition security piece. This is the food security piece I'm going to show you. It's a little bit shorter. So we assessed this with something called the Child Food Security Survey module. As far as we know, it's the first time in Canada that this has been used. It was developed in the United States by the Centers for Disease Control, and it's validated for students to self-assess their food security status. In Canada, we typically measure food security through a module that's done with the person responsible for food in a household, and they speak on behalf of children. Children don't answer that survey directly, so but you can't use that with this age group. So we can't compare this to national surveys of food security, but the flip side is we couldn't have used that module to collect this information. So what we see here is that, hang on. If you add, so we have two categories, moderately food insecure and severely food insecure. And we can see that in total, almost 1 in 20, well, more than 1 in 20 students was identifying as severely food insecure, and 15% were moderately food insecure. So add those up, it's just over 20% of the participants were identifying as having food insecurity. But this is the only one I'm breaking out by region to show you, and it's probably no surprise that you can see that the northern students in the north had a much higher rate of food insecurity than in other parts of the province. It's actually 36% from those students who were identifying in the north. So body mass index, a good nutrition epidemiology study wouldn't be any good if you didn't have body mass index. So that's a way of measuring body fatness. It's not a good indicator at the individual level. It is a good indicator at a population level, which is what we're doing here with the group. And what we can see is that the overweight and obesity scores together came to about 25%. And that's in line with other surveys in Canada that measure this. So, it's not great. Food behaviors and health indicators. So I'm not going to show you graphs and whatnot here because they're really big. And but what we did was we took these variables. Family dinner frequency. How often do you eat dinner with your family? How often do you eat breakfast? How often do you eat lunch? Where do you eat your meals and snacks? Do you purchase food at school through vending machines or cafeterias? What's your self-reported health? Are you trying to lose weight? Are you trying to gain weight? We asked if they'd taken a food nutrition course in school. We asked about if they thought it was important to learn about food nutrition in school. And we asked about sleep. So sleep feels like a bit of an outlier because, what's sleep got to do with nutrition? Well, sleep is a variable that is linked to weight gain. So it's an easy question to ask, and we threw it in because it's another variable. So we asked if they get enough sleep regularly, how many hours they had the previous night, and what, the enough sleep is just a qualitative one. Do you feel you get enough sleep? And then we asked how much they usually get per night. And we took those healthy eating index scores I showed you, and we stratified those against these variables. So what we found was that students that had higher healthy eating index scores, so the students that were better, had better diet quality, that higher diet quality was associated with eating dinner with your family more frequently, eating breakfast and lunch more frequently, eating breakfast at home. Surprisingly, having your morning snack and lunch away from home. Now, we don't have any information about what kind of school food they specifically had, these students, so we were just relying on what they reported through here. Making fewer vending and cafeteria purchases. So my point here could have been, maybe there was a snack program at school. Probably not lunch. Most schools don't have lunch programs. Fewer vending and cafeteria purchases. Them reporting that they had excellent or very good health, not trying to lose weight, and getting 8 to 10 hours of sleep per night, and feeling that learning about food nutrition in school is important. Is that my last one? Oh yeah, hang on, I'll go back. So yeah, all of these variables came out being significantly associated with having higher diet quality scores. So what do we conclude about all this? It's just another story for us in the nutrition world about, we really haven't moved the dial on healthy eating in our population in a long, long time. In fact, I don't have specific longitudinal comparators, but it's certainly not better. And the dietary patterns we're seeing are cause for concern. That's our nutrition insecurity piece. More females than males were not meeting key nutrient requirements. But that food insecurity piece is a big cause for concern, especially in northern Manitoba. Nationally, the last survey that was done on food insecurity across the country, Manitoba was sitting at around 14% food insecurity. And this survey is suggesting it might be a little bit higher. And did I mention this data was collected in 2018-19? So it was pre-COVID. And both of these are putting, them at risk for future health and well-being. So, we're going to do some more razzle-dazzle with our data, and Nikki, my PhD student on the project, is here, and she's going to be looking at food insecurity a little more closely and seeing, what was associated with food insecurity for this group. And we're also engaging in a pretty aggressive knowledge translation strategy that we really hope will help stakeholders advocate for resources, programs, policies to address these issues. Okay, good research is, got to talk about your limitations. This was not a representative sample. We used a stratified convenience sampling, method, which was really you're begging everyone you can to participate in your study. But it was pretty large. It's the largest, survey of youth nutrition and food security that we know of in the province. We did do, if you want to talk about weighting, we did do a weighting sensitivity analysis on it, and we were pretty good in terms of having representation from those 3 regions of the province. 24-hour recall food frequency questions. That was, we also asked about, I didn't show you this, how often do you drink coffee and consume energy drinks and things like that. All of it was self-reported, so there's recall error. It doesn't reflect day-to-day intake variability and may produce socially desirable responses. So this is kind of a laundry list of limitations with any kind of diet recall. There's volunteer bias. Not all school divisions participated, schools or children participated. Our consent form was all in English. There could have been parents who English isn't their first language. They're going like, I don't know what this is, and throw it in the garbage. I don't blame them. And as I said, the data was all self-reported. There were lots of challenges with this. And Dr. Alan Katz, my I'm the nominated PI, he's the PI. You know, he wants to write a paper just about the challenges of this, and I don't know if I have the energy for that. But, you know, this was primary data collection. I don't think I could ever do it again. You know, I mentioned there's 37 school divisions in the province. We had technical failures. I was up in Swan River doing data collection and had all these kids in the library, and I was with, it was one of the few times I actually went out. I was with the research coordinator at the time. And all of the data was collected on a secure server in Southern Ontario by a third-party company that the University of Waterloo had worked with. It was a really good setup, but something happened and their server went down and we couldn't collect the data. So we had gone all the way up and got all these kids. I remember the principals there like going, okay, like why isn't it working? And we actually had to leave without collecting the data from there. That was really bad. So that's just one example. There were some other, you know, Nikki, I think you were at some schools that had some little glitchy things going on. So there were, I mentioned about the paper permission and consent forms, you know, lack of standard nutrition assessment methods, the food guide, you know, we need a new way of assessing you know, dietary quality with the new food guide, which is, you know, like I said, people are working on it, but it's not quite there. And then of course COVID happened, and you know, even though we had collected our data, we had these school partners, and you know, once COVID hit, it was like there was like a fire, like no school is speaking to you. And once COVID started, they don't care about your dumb study. I mentioned we've got a lot of data, so we've already got some papers in the pipe around the food behaviors and health indicators, around the regional differences for everything. Papers have been submitted around the newcomer cohort. We're working with partners around the Indigenous cohorts. And then I mentioned the linkage with administrated through the Manitoba Centre for Health Policy, those 900 and, I don't know, Nikki, how many students are there? 957, and Nikki's going to be doing all that data linkage work, looking at relationship between some of the variables we've collected and things like mental health, housing status, you know, have students' families been in social housing, income level, school achievement, you know, how many credits did they get in grade 9? Are we doing grade 9? Grade 9. We were going to do grade 8, but we can do grade 9. And mental health, you know, you should all be asking, why aren't you doing other health? And why aren't we doing other health?
Why?
Well, why do you think? Come on, I got time. Someone guess. So we were assessing these kids' diet. I have like a coconut bit from my donut floating around. So we've got these kids. We took all this dietary information. You'd think, you know, I talked about diabetes. You'd think we'd want to, you know, see if they've, you know, got some health issues. Why aren't we looking at health issues through their administrative data sets? Yeah, like they haven't developed. They're in grade 9. They, you know, they really haven't developed chronic, you know, indicators for chronic disease other than maybe, you know, their weight or. There's nothing that would be through administrative data that would really give us any clues. They're too young. But the mental health variable, which Nikki is doing all the work on, that will give some clues as to, you know, how food insecurity and nutrition insecurity is related to mental health, because those students are, you know, experiencing, children at that age do experience mental health issues. Okay, knowledge translation. For me, this was the biggest part of this study. Is I worked in public health for almost 20 years. know lots of people out there. I would really like this to have an impact on what we do in the province around children and nutrition through schools. So we've got, I showed you the big list of partners. We've developed a report that is sort of a little more user-friendly than scientific papers. We're actually, just yesterday I had my first consultation around the report. I'm having another one next week. We are developing infographics, something called a Tableau dashboard. I'll show you that in a minute. We want to have widespread distribution of this, get some media buzz around it, to say we really need to do more than have breakfast programs in schools. So breakfast programs, sure, they're important. Those are to address food insecurity. But what I've showed you is we have many, many more students who have nutrition insecurity than just food security. So some breakfast programs in low-income schools or regions are important, but they're not gonna cut it. So this is just one of the infographics we've developed. This one's just on sort of the methods of the study. This is a Tableau dashboard. So there's a lot of data, and different stakeholders might be interested in different things. So this is just a still out of it. But what it is it's an online searchable interface, a dashboard, where you can see the select measure category for this one is not meeting food group recommendations, okay? And then on the right, we stratified it by region. So you can see that the 4 food groups are up there, and the dark blue bar is for all of the participants, and then the other colored bars are for the 3 different regions. So, yeah. So what our stakeholders will be able to do is go in and they can search for their region, they can search for the variable of interest they want, they could look up the healthy eating index or whatever, and it's kind of a fun interactive way of customizing the data, and then they can print it off or whatever. We just got our first paper published last week, which is the methods, and we presented some descriptive information, so it was, we were really pleased to see this come out. We've got some other papers that have been submitted and are doing some revisions on some. So we're doing the traditional knowledge translation as well. And I have a website that I put food nutrition education resources and information about food literacy on. And we will be hosting all of the results and our papers and the report and our infographics will all be available through here. And here's a question. We had COVID after we collected these results. So are these results still relevant, or are they, it was 2018, like COVID happened? And well, we still have skipped the dishes. And, we've got this thing called food inflation that, is all over the news right now. We did have COVID, which, got many children sort of, for reasons that we all know, lockdowns and whatnot, not necessarily living their healthiest lives. Food bank usage is way up, and, the government, they put $1.75 million in some kind of food security fund. I don't know what that's going to do. But I think the results are still very relevant, and we really want to capitalize on some of this to get our message out there. And that's kind of it. I want to acknowledge I have a really great team that helped with this study. And that's it. I'm done.
Thank you. Thanks, Joyce. Fantastic presentation. And I was going to ask you actually right away. You said you're never going to do this again. And I was going to say, well, post-COVID, you should definitely do it again. But anyways, I'll open the floor to questions. Fire away.
Yes.
Could you talk a little bit about protein intake in kids? And the reason I ask is we do a real focus on protein in the province here on the agriculture side. And there's a lot of protein-enriched things out there, and my son discovered protein in grade 11, maybe grade 9 group. He started working out, and now he's all about protein.
It's got big jugs of the William powder.
No, I won't let those in the house. It doesn't look right. But he did ask me, as I cook from recipes online, he said, do those recipes have the protein broken out? Which I thought was kind of a weird question. But are kids consuming too much protein, and is it at the expense of other nutrition?
I think Dr. House should answer this question. Oh, I'd have to go back and look at that, but I don't. That wasn't something that came out. Like when we did our macronutrient distribution, they had an adequate amount of protein, right, Nikki? Yeah. Jim, do you have a?
This published a paper looking at the quality of the Canadian diet using CCHS data, 2015 survey, and we looked at those that were eating primarily plant-based protein versus those that were primarily animal-based protein. The key messages that we got, we're eating about 64% animal protein in the diet as opposed to 36% plant protein. We want to see a balance between the more balance. We don't know what that number should be. I think that's an interesting question. But how people are eating protein is really interesting. Those that are primarily eating plant-based protein, you think it's, we're eating nuts and seeds and legumes. No, it's coming from bagels. It's coming from a lot of cereal grain intake. Even though cereals have their own place on the plate, they do provide a significant amount of protein. And so that's how, when you're eating plant-based protein, it's coming from refined grains. And that's the messaging that needs to go out to, from a literacy standpoint, is the way in which we eat protein is challenging, because we're not doing it the way Health Canada is advocating right now in terms of plant-based protein. As to the question of are we eating too much, I think there's another question about the quality of that protein, and we're only looking at crude protein intakes. And we argue that you should really be looking at quality of corrected protein, which tells a very different picture.
Okay, so complicated. But yeah, like a study like this just doesn't give you that level of detail. Dr. Entz, you had your hand up.
Yeah, so what is the aspirational number? What, for example, with fruit and vegetables, what do you think would be success?
And moving the dial away from where it is in a positive direction.
And how far do you think we could move it in our culture?
That's an issue, right? Fruits and vegetables are expensive. For many people, the availability, there's lots of barriers to that. Our food environment doesn't encourage fruit and vegetable consumption. If we're doing just walk around campus, right? Campus is a microcosm of what the wider food environment looks like. There's not a lot to choose from that isn't pretty highly processed and having more of the types of protein that Dr. House is mentioning, refined. How much? I wouldn't hazard to guess it. As a dietitian, I'd say like any move in the right direction is getting us there, and at a population level, we'd just like to see that increasing, and not just because people are saying they're eating more. I had some raspberry jam on that piece of bread, so I had some raspberries.
And then given that, if I could do a follow-up, so what would be the pathway, the policy pathways that you would suggest to get us to moving that needle?
Well, one thing that I am interested in is food literacy education for children and youth through the school system, which is what my other half of my life is all about, is promoting food literacy, and not just in terms of tips and tricks, but actually having it become a foundational part of children's education. We teach them about math, and we teach children about all kinds of things in school. Agronomy. And yet we've got the most complex, unhealthy food system in many regards in human history, and we do very little to help children cope in that. So I always show a picture of a kid drowning in a pool, and I feel like that's what we've done. So the policy in Ontario, they got Bill 216 in the provincial legislature. Of course, COVID came along, but that is a bill that would mandate food literacy education for all school children in Ontario, first in Canada. So I would like to see something like that. Yes.
I was wondering if cooking was part of that food literacy, like the actual skills of cooking.
Yes, that's why you see the person slicing the daikon on that. No, I'm just kidding. But yeah, absolutely, that's a big part of it. And if you explore my website, I develop teaching resources with former students who are now licensed home economics teachers. Every year they develop resources. They're not all cooking, but some of them are on here. So that's definitely part of it, yeah.
Because I was looking at that diabetes graph, and I was wondering how much of that had to do with nutrition, poor nutrition, or poor incomes, or how much both, but because I know a lot of higher income people who are still getting diabetes.
Because they have nutrition insecurity.
Yeah.
Yes.
And so is it because we're just going to be eating crappier, or is it because we're not going to be making enough money to afford healthy?
It's all those things. So, we have a food environment that really encourages people to eat unhealthy food. I mean, that's, you just look around you, right? If you're poor and live in Winnipeg and you're food insecure, you don't have a lot of choice, right? So chances are what you're getting through a food bank or what you can afford is you're probably going for, cheaper, highly processed kinds of foods that are going to, further increase your risk of these poor nutrition outcomes. Never mind that there's a whole host of other, mechanisms to chronic illness independent of your behaviors, just chronic stress and things like that. So my main message is, there's nutrition insecurity, there's food insecurity. If we just focus on food insecurity from a public health perspective, we're going to miss the mark. If you could get rid of diabetes in all food insecure people in Winnipeg, you would still have most cases of diabetes because most of the cases are happening not in that group. Having said that, the rate in that low-income group is very high. Okay, so even if you're just a pragmatist and don't want to spend your taxes, you want to address this issue across the board.
Good question. Jim?
I just want to ask a question about the consenting process. The parents were the ones that were consenting.
Yes.
What is the age of consent for this type of research? And does it open up the possibility to do a longitudinal study?
Oh, those are two really good questions. Okay, was it 16? I think it's 16 is the age they can consent. So we had to have parental. But going through the schools, I'm guessing if the schools would have wanted parental consent for anything you're doing with their students. We also had where students could do something called assent. So even though their parents consented, when they got on that computer to do their data entry, the first thing that came up was, do you agree to do this? And if the student had said no, then we weren't going to compel them to do it. I don't think we had anybody that didn't assent to do it, but it was an option. And then you asked about longitudinal. Okay, lest I go on a diatribe about what the Human Ethics Board was in 2018, when we submitted our protocol here, I tried. They would not accept it at the Bannatyne campus, who's familiar with this type of research, especially the data linkage research. It was a nightmare. It took 4 months, and I literally got approval the day before the chair left. The chair left, he left the position, left to go to another country for a year, and I got permission, but the one thing I had to remove was the provision to look in the future at any of this. I would have had to go back and get consent from all of those parents again, which is ridiculous, and we had to start data collection. This was at the end of August. We were online for early September to start our data collection. And it was like a deal with the devil. I had to take that protocol and go with it, and knowing we couldn't do longitudinal.
Do you still need parental consent now? Because most of those will be over 16.
I would have to go get consent from the, yeah,
Actual students.
that's right. So, yeah, it's unfortunate.
Any other questions to Joyce? Yes,
Trust.
please. Yeah, it's you. Yeah, in the group.
What do you think about the diet?
You know what? You're allowed to pull your mask down when.
What do you think about the dietary preferences among those children, like vegetarians, vegans?
We have no information on that. That would be a really good question to ask, you know, and like any kind of survey, after the second you're done, you go, oh, I wish I'd done this differently. But that would be a really good question to ask. Yeah. Trust?
Yeah, I was just wondering, after you have put together your website, how are you going to attract people to even go and capture all this literature which you are putting on your website? What's the draw? Are you going to develop an app or something to...
Oh. Yeah, the Joyce app. No, no. You know what? It's just a platform to host it. You know, as opposed to having like paper copies of stuff. I have network across the country of, you know, people who, you know, everyone from the Canadian Nutrition Society to teachers to people in public health, and you know, it's just trying to get it out there, sending your web link, and you know, I'm just hoping here in the province I can get some traction with some of this. So, yeah.
Hopefully these events drive some traffic. And these and other events when we distribute drive some traffic.
The gentleman behind you. Oh, sorry, Nazim, I'm doing your job.
You said that the data has
You know what? You're allowed to. Okay.
you say that the data has been collected from the students of grade 9.
Yep.
So now, like all the students who are studying in grade 9, they're not having the same habit. Like some may be more athletic, some may be more sedentary. So the nutritional requirement for each type of students will also be different. So how to deal with this discrepancy in the...
For sure. We're looking at this, that's why we're aggregating everybody together and comparing them to what we know are national dietary recommendation guidelines. Things like nutrient intakes, those food group intakes. You're absolutely right. There's variability, but you know, the size of our sample and you know, minimizes that, you know, the effect of that between person variation. It's not perfect. It would have been better if we'd done a second dietary intake. It's not a physical activity study, so we weren't doing, you know, metabolism, this and that. You know, that was just way beyond the scope of what we could do. What we'd love to see is that youth health survey come back, do a proper nutrition, physical activity component of it that could maybe factor in some of those things. Yeah.
Just to follow up, like, so do you suggest that this present standard, like which is presently the scale of studying the dietary requirements of people based on age, is correct, or it should be based on habits?
One of my colleagues, help me out here. You know, doing this kind of population level study, we really have to base it on age and what we know about people, you know, and pulling in these other variables. Like, you know, one way we could look at it is, I don't know, by weight status or by, yeah, there's other ways to slice and dice it, and that's probably the best we can do. I think what you're talking about is doing those more smaller scale types of studies where you're looking at the effect of a variable like musculature and activity level and other things, and how those are. I think that's beyond the scope of a. Having said that, there's the Canadian Health Measures Survey. Go look it up. I haven't looked at it for a long time, but they might have more of that type of thing you're talking about in it.
I have one more question. In one of your slides about food security,
Yeah.
Is the food security in rural areas greater than?
It was the highest in the north.
Yeah, but it was the
Best
second
in the
was
rural areas.
Rural areas and then the urban areas.
Right.
So, what's behind that?
I don't know. I can only speculate, and you know, it could be cost of food, it could be, you know, again, this isn't representative, giving us clues for other studies that we should go and do to see what's going on. Yeah, I mean, it kind of brings up more questions than it answers.
More grandmas storing food on farm. Any other questions for Joyce? Yes, Christina.
Yeah, you always, it is the intake of grains or grains-based food is related to obesity, and usually nutrition and dietitians are removing grains-based foods.
None of the ones I know.
Usually when you were to the doctor and you wanted to be on diet, they remove, you know, the carbohydrates from grains. But in your study, you saw that the intake,
It's quite low.
intake of grains is, and also it was kept almost constant between or among the three groups that you have, the overweight and all of them. So did you have that? Did you reach that conclusion also in your study? Did you relate that? So grains were related or not related? It was
We
related
have
to
not-
some better.
Yeah, that, I don't think we can do that with this data. That wasn't the purpose of it, to, you know, go in and look at anything sort of causal. You know, we're just looking at relationships through this data, and it's pretty descriptive for the most part. I think that, again, would be an interesting smaller scale study. But I think that's really interesting, and what you brought up, people are under the impression that, you know, oh, people are eating all these grains and that's why they're, and no, you know, we actually see they're not even meeting what's recommended. But, you know, looking back at those other foods and what else is in the diet, and that's more the problem area than grains per se. Yeah, I think that's an interesting finding, yeah.
Maybe one more, last question if you could.
Yeah, I just.
Go ahead.
Oh, you can, thanks. Yeah. One, I think it's a very good study, even with this observational study, but opens up ways to later do the true experiment to explore the causes. But at this point, I think because it is observational, we cannot say item A causes B, but opens ways for that. Well, but my question is regarding, if I understood that correctly, you somehow have the data for people around 1,000 with the Manitoba Health ID, correct?
Yeah, yes.
Do you have any plan later, 10 years from now, explore the whole thing?
Okay.
Feasible or not?
This is what Dr. House was asking, can I do follow-up study? And the answer is no. I do not have permission to go in the future and look at, you know, where did these kids end up? And, yeah, okay. Thanks, everybody.
Thank you very much. Thanks again, Joyce. Well, thank you, everybody. So you saw the health end side of things, but the faculty goes soil health, plant animal health, and human health. So come to the next ones and see what else we have to offer. Okay, have a great evening.